How do we encourage companies and entrepreneurs, whether they be currently working in Westmead or want to come here from somewhere else, how do we actually encourage them to come? How do we curate those relationships and curate the precinct in terms of being open and available for entrepreneurial activity? So we actually had, I don't know, is Chris Camadas here today? No. So we had Chris Camadas, who's an amazing guy. He's the head of strategic partnerships and innovation at Health Roundtable. He had a challenge in being able to come here because he was coming from Brisbane, so he obviously wasn't able to make the quarantine. His colleague's here, fantastic, excellent. Well, can I ask, sorry, I haven't got you on my updated list, but come up and grab a seat, and we will introduce you in just a sec. But also Dr. Clara Chow, Professor of Medicine and Academic Director of Westmead Applied Medical Research Centre, Sally Ann Williams, CEO of Cicada Innovations, and to chair this panel, Geoff Roberts, AM.
Hello everybody. This is about innovation and getting stuff happening quickly. But by the way, those people that keep saying, where's the leadership? I'm the leadership, okay? So if it doesn't happen, I've got the red dot on the forehead. So the Premier wants me to deliver Westmead. So if anybody is not clear about that, then maybe you can talk to me later. I have an organisation around me. Troy Daly is here, who's going to be the day-to-day leader. Troy, can you just stand up? Most people know Troy. We have Jackie Taranto, we have Peter Poulet, but ultimately as the Chief Commissioner, I am the single point of accountability. Now that we've dealt with that. Innovation, how to make sure that the government doesn't create sort of Soviet Russia and try and over-engineer everything and allow the green seeds to be released is really about what this next half an hour is about. These three wonderful people are here to give us some help about this. I don't really know Clara, and I don't know you either, but I do know this wonderful person in the middle of the room because Sally Ann and I work together on Tech Central. We're not moving Data 61 out here. We're going to have CSIRO enterprises in each of our three core precincts so that we've got a technology superhighway between Tech Central, Westmead and the Aerotropolis. That way the whole of Sydney can prosper rather than one part of Sydney. But on that basis, Sally Ann, tell us what Cicada does and tell us about your amazing experience in the startup and the scale-up world.
Thanks, Geoff. First of all, show of hands, how many people know about Cicada Innovations? Okay, I'm probably...
Who doesn't?
Great. I'm actually going to probably educate most of you because what you think you know about Cicada you probably don't know, for those that do. So I'm the CEO of Cicada. I've been there 20 months. I joined Cicada Innovations after running Google's engineering R&D team in Sydney for nearly 13 years. So when we talk about Silicon Valley, and we'll come back to that, I can bust a few myths with you on that one and what that is as a precinct and how it actually started, and it's DARPA funds and it's defence funding, but anyway. So 13 years in Google Australia, building the engineering team of 11 when I started to over 800 when I left. Cicada Innovations is 6,500 square metres at South Everleigh, right next to Redfern 10 train station, and we will be 21 years old in August. And we exist solely to commercialise deep tech companies. So these are engineering and science-based businesses. At the moment, we have 43 residents employing over 450 people. 40% of the companies in that space are medtech companies, and of that 40% of companies that are medtech companies, more than half of them are diagnostics and therapeutics companies, as well as device and software as a medical device. We also do energy, we do new battery companies, we do ag tech. So the thing that Geoff was, I think, somebody was struggling with earlier today, we do that. Come talk to me about it. I'll explain it in 30 seconds. And we do heavy infrastructure. We are owned by 4 universities, but we are independent of those 4 universities, and we run a sustainable business commercialising deep tech. As deep tech takes time, everything that you're wanting to do in this precinct, the companies that you're wanting to grow and you're wanting to start, if you start one today, it's probably going to be 15 years before they have a product in market, and 20 years before they become an overnight success, and 30 years before they maybe have an exit. 21 years old, we've had 5 exits via trade sales or IPOs, delivering $1.1 billion back to the shareholders. Sadly, I am not a shareholder, and we are not a shareholder in all of those. And we've produced well over 2,500 jobs. Last year alone, the companies in our resident portfolio raised over $100 million during COVID. We became the fullest we've ever become in our life, and we are attributing companies out into the ecosystem, into that halo effect. Not in a precinct. We don't think about precincts. We just think about where is a building that's appropriate for them that they can afford, and let's get them into it. And we had more than 100 people join our businesses last year. So we're probably one of Australia's best kept deep tech secrets, and we don't think about our 4 walls. We think about how do we collaborate with the best and the brightest who want to solve the world's most pressing problems, and we put our networks, our mentors, our money, our people, everything around them. One myth I just want to bust really, really quickly. I love universities. I'm owned by 4 of them, and many of the representatives of them are in the room today, so if I don't say nice things about it, it will definitely get back to my board and my shareholders. But we need to bust open a linear myth that all research and development and translation of research development starts and stops and comes from universities. It actually comes from anywhere. And when we think holistically about how we work with universities, that's where the opportunities lies. Of our 43 residents, right now, only 1 is a direct spin out from a universities, and it's an energy company. All of my medtech companies are not spun out of universities, yet every single one of them employs graduates from the universities, here and globally. They do collaborations, they do industry PhD programs, they do development, they do manufacturing on site. So we are a little microcosm of an ecosystem, but one thing we are really proud of is we're not just inside of our 4 walls. We actually work globally, and today we announced a partnership with CSL Behring to launch their latest innovation challenge. So, you know, we want to work with you. We think we've got great outcomes. We'd love to help you on the innovation piece.
What do we do at Westmead differently to what we did in Tech Central for the last 21 years?
I think one of the things that, and people have touched on this, you've all talked about governance and leadership a lot. You need to create space and place for entrepreneurs to thrive and flourish. And as much as I love beautiful, shiny new buildings, they can't afford to be in there, and they can't afford to be constrained. One of the biggest myths about Silicon Valley is that it was a designed precinct. It wasn't. Google, when they started building, moved to the cheapest, scungiest places. They started in a dorm room and graduated to a garage. You know, people startups need to have the space and the place that is cheap and grungy to thrive and survive. And they actually, for investors out there that are into development, you should come and talk to me, because we'll come and put a spot in there, and in 10, 20 years' time, that building is going to be worth 3 or 4 times the value, not just because of what's happening inside of it and the capital that we've invested into making that amazing, but actually the companies that we're graduating out into the developments that you want to do around it. So Silicon Valley is much more organic than what anybody thinks, and it's also much more than Cupertino, and it spans over to Oakland right now and is almost Sacramento all the way down to San Jose. And it's a mess, quite frankly, but it's a beautiful organic mess. And so if we can get some organic capability to Westmead, I think that's going to be really helpful as well.
Clara, what's your view?
My view, okay. Can I talk Westmead? Can I ask a question? Do you know where's the best place to have a cardiac arrest in the world? No, that's the problem. It's not the best place to have a cardiac arrest in the world. A cardiac arrest is probably, you know, as people know, one of the worst ways we can see heart disease presenting. It's sudden, it's horrible, but you know, actually there's a lot of knowledge out there as to how we can actually impact on outcomes from cardiac arrest. In Australia, generally speaking, only about 1 in 10 people with a cardiac arrest leave the hospital. But in some parts of the world, that's actually 4 or 5 in 10. So do you want to be in those places rather than those? Now, I'm bringing that up because cardiovascular disease is unfortunately still the leading cause of death in Australia, and Western Sydney is infamous, famous, got a lot of cardiovascular disease. We have people that have younger heart attacks than any other place in Sydney. We have people, our average age of heart attack here is 59, whereas in places like the North Shore and other privileged parts of Sydney, it's more like 70. So I suppose I put that to you as a problem that we do need to innovate in. And I tell you that because, you know, a cardiac arrest happens in the community. The hospital is here, right? In the first 10 minutes of a cardiac arrest, we need people to respond. We need them to give them CPR. We need people around to grab an AED. We need people that know how to do that. We need them to call the ambulance. We need the ambulance to get them through those roads, get it to Westmead Hospital. And we need the best doctors and people to work on them quick with the best innovation and tech. And we need to support those patients back into the community. We need to get them there quickly and support them with this great remote monitoring that we can now do and care for them and ongoingly support them so they can get back to work and stuff. But as you can see, I mean, I'm a doctor, I'm a cardiologist, and yes, you know, I've had the privilege of having fantastic relationships with patients and being able to be part of their lives, but I can see that I can't fix that problem without, you know, working with multiple groups here in the community. And, you know, obviously that's part of why I'm hanging out with you guys now. But, you know, I suppose, you know, having these challenges and identifying these problems where we can all work together and innovate together is, I think, a good place to start in terms of talking what innovation is, because innovation is about taking a problem, a really important problem, and doing something different with it. It can be simple, but it can be really effective. And I suppose...
So what is it at Westmead? What do we need to do at Westmead to fix or help fix population health that makes you unemployable in 20 or 30 years' time, because cardiac health has dramatically increased in this part of the world?
Well, I'd love to chat to Malcolm because, I mean, he made this comment that, I think he made the comment that he didn't know what happened to the health outcomes of all of the communities he modified with his amazing, you know, design and change. And you know, I'd like to say, surely we can work that out. I mean, we've got terrible health outcomes in this area. It would be fantastic to see them change. It would be fantastic to have that data walk through the door and everybody sign up to hook their data in so we could see that change. I worked a little bit on the ADHA My Health Record, and you know, it's an amazing thing that Australia tried to do, get My Health Record happening. But the problem is that, well, part of the problem is everybody can opt out of it. There's so many options to get out of it that actually I tried to look through My Health Record for a bunch of 100 patients and I could only get into 40 of them. So that kind of, you know... So
data is, a number of previous people have spoken about data. Data is one area, yep. But linking the clinicians into the practice of precincts seems to me to be another area that we should be talking more about.
Can I just add to this? Because something Clara was saying I think is really important to recognise, and it goes to the heart of this conversation, is she's talking about community...
You just made an unintended pun.
Did I? Oh, sorry.
You said to the heart of the conversation.
You can pay me for that in the lols later or something. I didn't mean to do that, gosh. Secondary career. But one of the things I think that you just touched on, which was so important and valuable that I think hasn't been discussed today, is that collaboration with connections outside of Westmead. Right? We're all talking about what happens inside of Westmead, but if Clara wants to see people coming in the door that are healthier and that are having heart attacks later or not at all, that actually is out there. And that means we've got to have a hyperconnectivity between not a precinct, an artificial precinct wall, but we've actually got to have a hyperconnectivity with community and people. And it's not just physical data, it's actually that relational data. And it's who out there is working with community that can influence what children are doing in schools and how families are eating and where they're purchasing and procuring food for, of what's being planned around their areas. Are they healthy foods? Are they not foods? Is there movement? I'm not a doctor, so I don't know, but I'm assuming these are all the things that, you know, there's a lot of things that can be done in a community intervention that would actually impact what happens inside of Westmead and vice versa. So finding those actual connection points outside and stop siloing ourselves to just precincts. Precincts are important, but actually that hyperconnectivity is more important.
Do you want to respond to that before I go to Dennis?
Yeah, look, absolutely. Context matters, place matters, and that's been a theme here. So if you don't have access to healthy foods and places to do physical activity and you know, good jobs and less stressful environments, yes, you know, this is all part of the reason why we have poor cardiovascular health. But it's also got to do with health systems and access. I mean, you know, we're having a bit of a chat last night about, you know, how much do we pay out of pocket for healthcare here in Australia now? I mean, we're actually paying a lot now out of pocket for healthcare here in Australia. That's a problem, you know, and how can we do that differently? Well, you know, in COVID, as you do last year, we started this demonstration project where it was called Heart Health. We, at the end of discharge, we sent a single text message to all the patients being discharged from hospital, and they got to opt into an education support program from us at Westmead. With a single text, over a third of patients opted in with a single text. And, you know, my small team of 2 are now supporting about 5,000 people through this texting program. And, you know, they love it because we get messages back like, I've gone for my walk today, and, you know, I've done what you said. I've now made a fish meal. You know, we get the thanks. I've done it. I've already done that, doc. All of that sort of feedback through the basic text. And I suppose that's a simple way, you know, it's talking about simple ways of supporting people. Admittedly, I have no idea how to pay for that program, and someone here can tell me how to do that. But anyway.
Thank you. Dennis, tell us about you and what your organisation does and what you would do to encourage a collaborative and innovative ecosystem at Westmead.
Right. So my name is Thomas.
Hello, Thomas.
That's all right. And I'm stepping in for Chris, so that's the bigger picture here. Bit of street cred maybe for the audience here. Obviously, you don't know me. I was the chief executive of 2 startups in the past, one an Australian, Sydney-based, orthopedic surgical instrumentation, New Zealand surgeon, worked with RPA and Sydney University 15 years ago, commercialized it, sold it to a Swiss manufacturer. The other one was an imaging IT solution, and that was a Singapore-based company, and that, or Singapore-based startup, that is now listed on the ASX. So I have some experience in, you know, not maybe the Silicon Valley type. So I'm director of our membership at Health Roundtable, and Health Roundtable is really a non-profit organization that thrives on its membership. We have about over 200 hospitals across Australia and New Zealand. And what we do is we also instigate as well as facilitate innovation. So instigate, sometimes we bring in things that we think might be useful. We work with the Mayo Clinic, for instance, last year to bring in one of the measurement tools. Now 12 hospitals and 20,000 staff are using it across Australia and New Zealand. So that was a kind of a potluck we tried, and it seemed to be working. The other one is every year we have a innovation conference where our membership can come in, and it could be anything from a new process, it could be a new technique, a new way of clinical administration. And there is a voting system that the membership votes which are the best and also the most applicable ones. And then we look at how to propagate that across the membership. Now, the analogy could be, is you probably are all aware of the ship stuck in the Suez Canal. And let's say we have 2 tugboats to pull it away, and we have dozens of pilot ships. I could send the 2 tugboats out there and think, maybe pull it this way, or I can send the pilot ships around the ship and see which are the weak points, and then send the tugboats based on that information and pull it from in the right direction. So the point is, I'm trying to make is that there is no shortage of people wanting to participate in innovation in the healthcare ecosystem, entrepreneurs, also, you know, tertiary institutions. The point is the contribution, and the contribution has to be based on who does best and how it is validated. Then there's a progress. If we try potluck, a shotgun approach, that won't work. If we just try one of big approaches, that won't work either, at least from my experience. So how to prioritize and how to get the right people together is, of course, not an easy task. And that's, I think, for Westmead will be absolutely critical to get the right membership, if you will, to participate in this journey.
A question to all three of you. How important is digital connectivity? Can I just contextualise this question? For the last decade, maybe more, 15, 20 years, the New South Wales government has been on a significant people moving transit-based capital works program, which will total $100 billion, right? We didn't do anything for 20 or 30 years, so it's kind of catch-up. But it occurs to us in the Commission that the challenge for the next 10 or 20 years may be more about moving electrons around our city rather than moving people around our city. And certainly the post-COVID world, it seems that blended workplaces are here to stay. What is the role of high-value digital connectivity? It keeps me awake at night that Seoul in the Asia-Pac region has the #1 digital connectivity of any city in the world. I think we rank 67th at the moment. How can we be an entrepreneurial city with these major, forgive me, precincts located along our axis if we do not have world-class digital connectivity? How important is that? Sally Ann first.
I think it should go without saying that it's absolutely foundational, but I think we have to get it right. Right? And there's a lot of talk around in all of the precincts and beyond about what connects to what and who gets access to it. And there needs to be a parallel track, because if we don't have public infrastructure and if the public can't connect to it and they can't experience it, we're actually not being inclusive, and we're also making it harder than it could be. Now, let me give you a really tactical example. Again, love universities. However, when I visit universities around Australia and I go onto their campus as a guest, it is almost impossible for me to get access to the internet. And it's almost impossible for me to wayfind around the place. That shouldn't happen. So interoperability, thinking about that, thinking about how we think about cybersecurity, all of those things are absolutely critical. The e-health one is really interesting, right? Full disclosure, I'm going to give you a Google story here. So many Googlers opted out of that because we got the policy settings wrong. It was no longer health professionals having access to my data. It was potentially the police. It was potentially other agencies who, on the face of it, should not have access to my data. So we've got both the connectivity issue, but then we've got the data. And data rights become human rights when you start thinking about who has access to what and to what means they can use it. So we've actually got to get some really complex policy settings right in that space. And I would say that we don't always have the complexity of that conversation framed in the right way, but from an infrastructure perspective, there's absolutely no reason that we can't have publicly accessible, high-speed, great internet available across all of those things, and they should be hyper-connected to each other, because that actually facilitates greater conversation, not just between people who are in the precinct, but also patients and community. And we've got to remember they need to be engaging with us in this.
Clara?
I'll give a one plug back to Google first, because, you know, in my recent meetings with Google, they would only let me use Google Meet and not Zoom. So there are other ways of locking groups out. At any rate, I think it's paramount to have you know, good digital infrastructure, and I think it's paramount that it needs to be accessible to all, as in like water. And I suppose, you know, one thing we're conscious of is that it could create another hierarchy. And we're very conscious of that.
The digital divide.
Yes, in the health space. I mean, you know, our groups of our lower SES groups are already struggling to access healthcare. And if we create another access block in that they've got to have a great computer with great internet, with great, you know, video, sound and everything, that could be a real, you know, bad thing. So absolutely, but really need to address that. And I suppose with the health data thing is, it seems like more of a governance issue than it is a technical issue, but that definitely needs to be dealt with too.
Okay, Thomas?
Sure. I think there are two aspects of it. One is the foundational one, which is the infrastructure, the pipes. The second one is the content, the data itself, and the fluidity of that data. If we look at healthcare in particular, there's a lot of information that still sits in silos even today. If we put it into international context, HIMSS, which is an international organization, ranks hospitals according to different MRAM level. MRAM 7 is the one that is all connected, data analytics, AI is working, and number 3 is where there's some EMR implemented. And if you think about Australia in that space, we're about 30% in that level 3 or below. So if you compare it to, for instance, Singapore or to the UAE, Abu Dhabi and Dubai, where we also have customers, they're up to 80–90%. So it's not just the pipes which are essential. I fully agree with Sally on that one, but also the content, how we distribute that content, who has access, the governance of it. The right person should get that information at the right time.
Can I just add one other thing that I think is really important, and this is around machine learning and AI. It's absolutely critical that we make sure we don't have that we understand that we have completely biased data sets. So to Clara's point earlier about privilege and access to healthcare, if predominantly our healthcare system is accessed by a certain demographic people, and maybe it's disproportionately gender-based as well as, you know, cultural background or things like that, the data sets are going to end up being biased. And it actually is an incredible problem that we don't talk about enough. It's really critical in a couple of areas in Australia where we're thinking about this right now, in both banking and in health, that we actually understand the limitations of our data sets, and we're ensuring that we're actually figuring out how to do that. Now, there's another concern if we think about our First Nations people and data sovereignty and cultural rights and cultural heritage, and how do they become custodians of their data and their culture and their story. And I don't believe health is completely disconnected from country and people in those cases. So it's quite a complex conversation to have. It's not one we should shy away from, but it's one that we do have to raise the understanding of people who are decision makers and who have the governance structures in these places to really deeply engage with, so that we can actually do it right and well for the betterment of all people and the inclusion of all people in that conversation.
Can I make one quick additional? So, I mean, you brought up unconscious bias, and I think we have unconscious bias all over the place. I keep on tripping over it in lots of different sectors. But, I mean, one thing in Western Sydney is diversity, as we probably should be talking more about. You know, simple thing, looking for material to explain things to patients, and thought, okay, well, maybe I can find these just in other places in other languages. It's actually amazing how much of our sort of educational and health promotional material are not in any other language besides English. I mean, there are other ways of communicating, like visually and other things that don't require just sheer sort of written language, but we really need to sort of raise the game on that. And I suppose another thing with digital literacy is being able to address some of those things with smart tech, because can't I speak through this and the babblefish talks out that? I mean, you know, if we can start utilising the technologies and digital, you know, to cross that divide, that would be another path.
If I can just add to that one, very much so about the importance of education, but also the understanding of data. So we're moving our system from a PDF to an online tool, for instance, and we just recognized a lot of the hospitals would need to be educated on how to interpret the data as well. And these are the clinicians, the staff, everybody. So that's a very important aspect of it before we start about talking the other bigger picture.
Okay, you're Premier for a day and you can do one thing in innovation and entrepreneurship at Westmead. I'm filling in time here to get each of you to think about what you're going to do. We don't need wishy-washiness, we need specific deliverable outcomes. What would you do? Sally Ann?
I'm going to give a completely biased answer towards my own organisation here, but we have a free program that we launched a few weeks ago thanks to New South Wales Health and Medical Research called MedTech Foundations, and I would make that something that is part of every clinician's, every healthcare workers, everybody within the precinct, an opportunity to go through that program. It is available free, it is online, but I would actually create a community of practice on each site, in each hospital, in each research group, and I would say let's do it together, because we're actually going to raise the bar about the conversation of what innovation is, and we're going to raise our knowledge level together, collectively, because a rising tide floats all boats. So we're going to just start there, and then we're actually going to start our communities of practice to go, in the next 6 months, what's one thing that we will do to change our immediate ecosystem and to grow something here and empower people to do that at a local level to start making change and to just get it done. Don't wait for permission, ask for forgiveness.
Clara?
Well, I think that there could be a lot of things, but I think I'm going to use that opportunity to say that I would cut or address the barrier between primary and community care and our hospitals in managing health data. It's still crazy that I send letters and use the fax machine. I think, you know, the Precinct needs to sort that out, and I know that we keep on saying it's primarily as a, you know, federal state, but we really, really need to sort that problem out.
Thomas?
So what I would do for Westmead is set the objectives, identify the stakeholders.
Hold on. What objectives? We've got 37 documents with objectives in it.
Set 1 or 2. Reduce that, make it very sharp. Identify the stakeholders, invite the participants and facilitate that sort of communication, either by taxes, as we heard before, or by facilities, or just creating that innovative environment that allows companies to fail too.
Okay. I'm going to have one final one. Did you notice in the previous panel how polite health workers are generally and how polite they are in Westmead when the question was asked about what's Westmead going to be famous for? I find this quite culturally overwhelming sometimes. If health workers were investment bankers or chief commissioners or much ruder people, they would have been much more specific about what they're good at. I think Westmead is... Sorry, when you spoke earlier about your experience at Wellcome, they had a noble purpose. Their noble purpose before you started any physical works was to map the human genome. We, it seems to me, have the opportunity of being able to solve heinous kids' cancer here through gene therapy. That's what we should be famous for. And all the innovation work should be aligned with that noble purpose. The reason that our colleagues are nervous about saying that is they're worried about annoying the other 12 major hospital precincts in Sydney, and we can't have that anymore. So what I would do is align behind a singular noble purpose and get on with it. Thank you so much for listening to us.